Good morning, my future retina consultants. Today we will continue one of the most exciting sessions in the retinal surgery course, which will be the most practical one. Actually, I'm so excited about it because when you see what we have been illustrating in the past sessions practically and with videos, it will be seeded and implanted in your brain, and you will have another picture in your brain about it. So you will change your diagnosis, you will change the way of treatment and the way of dealing with retinal holes and retinal detachment, and like this. Once you see what's really happening, you will never forget it, okay? Let's start. First of all, we were talking about the BVD and the retinal hole and the retinal detachment, but we are just imagining it. Why don't we see what's really happening? Okay, let's start. First of all, this is the fundus, okay? This is the anterior segment, this is the iris, this is the space for the vitreous and the vitreous, and this is the retina and the optic disc, obviously, okay? So, what's really happening here? This is the vitreous, okay? This is the vitreous. o- The vitreous is transparent, as we see here, and the posterior vitreous detachment happen with aging normally. It's not a pathological process, it's a normal aging process. But during this normal aging process, we keep praying that it ends normally without complication, because you remember what I told you, that vitreous is the bad neighbor for the retina. We just pray that vitreous go away from our house without harm, okay? So it keeps separation when we are young. This vitreous is almost tangential with the retina, but with aging process, the vitreous change from the jelly phase to liquefaction. So starts forming like a minor here, called this is a hyaloid membrane. Okay, so this hyaloid membrane is supposed to be separating the this jelly vitreous from the retina. Okay, but with aging, two things happen. First, this jelly is transformed into liquid, and this membrane is no more strong, so it's no more a powerful barrier. So what will happen? Liquefaction here, and then hole in this membrane, it's done. What will happen? Liquefaction and leakage of this liquid material, liquid vitreous, into here. So what will happen? Elevation, because it will be subhyaloid, so it will form elevation of the hyaloid and separation of the hyaloid, which we call it posterior vitreous detachment. Okay, so Dr. Sharif, all what you're saying is normal. That's right. But during this detachment, maybe you have a small area that's strongly attached. Actually, it's probably due to epiretinal membrane formation, due to tractional force. It may be due to that end with traction RD. Many reasons. Okay, but you have this the sticky traction. So what will happen? Let's see. So during this is sticky, as we said, and this PVD and posterior hyaloid and vitreous keep separation. But this is still attached powerfully to a small point of the retina. A small point, which mean it is not as power as the whole retina. It's weak and can be detached or can be separated easily. So what will happen? Keep pulling till what happen? Till during the separation a hole is formed, or let's call it a break. Okay, so what will happen after this break is formed? We will have this picture of the hole. This vitreous, this liquefied vitreous that's here and also were accumulated here during the BVD, will leak into this opening in the retina to underneath the retina, to under the neurosensory. So what will happen? It will end with rhegmatogenous retinal detachment or something like this. Okay, so this is the idea about the hole and vitreous liquefaction. So we now understood the idea of the vitreous and the retina and the hole. So Dr. Sharif, tell us more about what happened when we have a hole, when we have this hole. How can we deal with it? if we have a retinal detachment that may be as a complication of all. Also, how can we deal with it? Okay, let's start. Now we agree that we have a retinal break, whether it's a hole or a retinal tear or whatever. So how can we deal with it? Okay, let's see. This is our fundus and this is the separation, okay, that we are talking about. And during the BVD, a retinal tear formed. A retinal tear during normal BVD, during tractional RD or whatever. At the end, we have a tear. How can we deal with it? Actually, we make, if we use three to seal the retinal break, we have three schools or three ways, as we discussed the last session, whether by laser photocoagulation, which is great but needs easily accessibility, or by cryotherapy when you have difficult accessibility and you can operate from outside the eyeball, but it's somehow a little bit destroying to sclera and the conj and the conjunctiva. And we have the diathermy, which I call it the old school, which is no longer very common. Okay, so here let's start with photocoagulation. Okay, we have two rows of laser. Actually, it's an argon laser around it. Actually, prefer two rows. I don't consider it a perfect uh, photocoagulation. So if you ask me why, Dr. Sharif, are we making these two rows? For two reasons. First of all, we are burning the retina around it. This is a healthy retina where we are shooting. Why are we shooting healthy retina? It's okay if we shoot a small area. This is small area that the patient may not notice. Okay, but we are stopping the processing and complication from this tear, because this tear may turn into a horseshoe or U-shaped or fish mouthing phenomenon, which this will keep elevating and separation till it reaches the macula and you have no longer macula on. So this is macula off and your patient became blind. So we are stopping the progress of this tear, and also we are stopping the leakage of fluid that has entered from the tear. So we're not just stopping the tear, we're just stopping the fluid that that is the subretinal that causes rheumatogenic RD. So it's very important to have this laser photocoagulation as soon as possible. The early the laser, the less the complication. Okay, this is how we make two rows, and I said this is not complete. We should have two rows, especially from the side of the macula. Typically, it should be done all around. Okay, let's see the other score when we have no longer accessibility. This is the retinal tear. Okay, that we have, it is the same tier as above. So what are we using? We can't access from here. Maybe you have hemorrhage, have trauma, whatever. You have no longer accessibility. You have a small pupil which can be dilated, whatever. You can't have laser passage from here, and you can see this side clearly. Or maybe this tear is not here; it's here anteriorly. So you can't see because you only see in a straight line. You can't have this turned picture. Okay, so what are we using? Instead of dealing inside the fundus, we are dealing from outside. Can you see? This is the cryoprobe. Okay, and we are dealing from outside, uh, like from sclera and the conch. That's why I'm telling you it is somehow damaging to them. And if you ask me what's the difference between them, actually it is the main idea. We are just using different tool. What is the main idea? We are causing this and fibrosis of this retina. So the tear and the fluid can no longer leak to the healthy retina. It is the same way. Okay. So can you see? This is a cryo, as if this is a low temperature. Okay. What will happen? It spread the very low temperature here, which will cause death of cells. So it ends with this fibrosis of this tear. Okay. The third way after cryo and laser for sealing retinal breaks, actually it is diathermy, and it is the same idea of the cryo, and it is somehow not very commonly used, so we won't dive too much in it. Let's move on to the next. Okay, when you are dealing with relieving vitreoretinal traction, how can we do it, and or actually how can we deal with RD? This is the detachment, which means that the retina is detached, part of neurosensory retina is detached from the whole normal retina. Okay, so how can we relieve this detachment? This is our problem. How can we deal with it? At first, we were thinking about why don't we relieve the pulling force here? Okay, whether by maybe by vitrectomy or by using air pressure like pneumopexy. We are using air to push the retina and return it to its place. Then a brilliant student raised his hand and say, wait. What are you searching for? You are searching for bringing the retina to its normal place. We are not thinking about returning the detached to the normal or the normal to detached. You don't bother it, right. Okay, why don't we bring the normal retina to the detached so we can relieve this abnormal space or this abnormal detachment? We said it's okay, let's have a trial. How could you do it? Okay, let's find. He used the scleral buckle. What does it mean, scleral buckle? Like this. It's like a pelt, like a tight pelt. We are bringing here this normal area to this detached retina. Actually, we are pushing from the choroidal side and from the scleral side to inside. In on contrary to what to the other two solutions, which is the vitrectomy to release the pulling force here, or pneumatopexy, that also push this detached retina to its normal place. And if you have a good look here, you will understand all the complications that I've told you about the scleral buckle. You remember? Can you imagine how much ischemia is in here? Actually, it is a strong pressure and strong tightening around the eyeball. So you have ischemia to all the vessel. Sure, all the vessel coming from the back of the eye to in front of it, to the and from posterior to the anterior segment. So you have anterior segment ischemia. When you keep pushing it, the eye is like a balloon. So what happened? You brought this area narrower, but you extended this area just a little bit. This little bit actually is making 1 or 2 diopter. So you are having a myopic shift in your patient, and you are also increasing the intraocular pressure and all the complications that I told you about in the scleral buckle. Okay, so this is the scleral buckle I'm telling you about, and this is not the typical. Not every scleral buckle should be like this. This is the circumferential type, and I told you there is a segmental, just a segment which may be radial or whatever. So all of them have the same idea that we are pushing from the side of the choroid from outside after elevating the recti. Can you see this is the muscle, the extraocular muscle? We are relieving the muscle with hook before the buckle, or you are exerting a limitation on extraocular muscle. You will end your patient end with squint. Okay. So Dr. Sharif, you have told us about the scleral buckle, and we got it. Why don't we continue to the other two ways, which is vitrectomy or using pneumatic retinopexy? We agreed that pneumatic retinopexy, what which means that we are fixing the retina using air. Okay, so here we are having the tear on the retinal detachment. From the first look, we are having a tear, so obviously it was erythematogenous. The tear was open, then fluid were accumulated here. So we need to close the tear and to push this detached retina against its normal place. So how can we will do it? Let's see. Actually, this is during injection of the air, what will happen here? Okay, but let's stop here. You have injected like the air or the gas bubble or whatever, and it has elevated and pushed the retina against its right place. But you have to remember when I told you in pneumatic retinopexy we are depending on the patient so much. Why? Because it's all about hip positioning. Because if the patient is in a wrong hip position, what will happen? This air bubble will be accumulated toward the optic disc, or it will be towards inferiorly instead of superiorly. So uh, we are not getting any benefit for it. So if we use only pneumatic retinopexy if you are sure about your patient, he's compliant, he's healthy, he can't move his head in the position where you ordered him to. Okay, that's how the air bubble. And I brought this video specially to show you this. What are we using here? Exactly, we are using here cryotherapy. Why I brought this video again? I brought it to tell you a fact that when I'm telling you different ways, it doesn't mean that we only use one way in the surgery. Here we used pneumatic retinopexy impressing against the retina, while we use the cryo to seal the break. So they are not different ways; they are complementary to each other. Okay, let's check the last one, which is vitrectomy. Okay, vitrectomy, it means removing of the vitreous. Okay, and uh, that's why we use it in many situations. O- this is the way. Actually here we this is the light source, and this is how we use or how we can get the vitrectomy. Okay, after completing the vitreous, which may be the source of this detachment or the source of this tear, especially in the case of tractional RD. Okay, so it will be pulling the retina away from its place. So I am separating the vitreous and taking it out with vitrectomy. And guess, will we leave this whole space like this? Of course not, because if you left it like this, you may face recurrent RD. So I prefer we have a substitution for this vitreous. Okay, so here we are carrying out vitrectomy. Okay, like this, and after making sure that we have ended the vitrectomy, we will inject any other substitution for it, like what? Like the gas we have used before, like fluid, like BFC, like silicone oil. You have many options according to the case, according to the pathology that happened in first place, that what was the cause of the retinal detachment, what was the cause of the retinal break, like this. And everyone has indication and contraindication, and we will illustrate it. Okay, so here we are injecting whatever, like silicone here. It's probably this is a silicone oil, and actually silicone is one of the most common used as substitution after vitrectomy because it has many benefits and somehow less complications than other options. Okay, so now we have used the silicone, and the silicone probably will be removed after 6 months. And in some cases actually we leave the silicone oil like forever, like in cases of recurrent RD or in single eye, according to the surgeon judgment and what he has seen during the operation. And how, what is the probability that during the silicone oil removal that the retina will be detached again? Actually, to your shock, it may detach it during the operation, during silicone oil removal. So it's something you have to be very cautious about. Okay, and here to be very sure about closing the tear, we used also laser photocoagulation. Okay, and in this case, in laser photocoagulation, and I told you this is if you can if you can carry out laser photocoagulation for tear, you should put it as your first option to make sure that it is sealed to avoid any subretinal fluid accumulation or fish mouthing phenomena or whatever. Actually, silicone or heavy fluids or CF6 or C3F8 or whatever you're using, all of them are called the tamponades. And from its name, we use tamponades for as a vitreous substitutes for pressing against the detached retina to avoid any other complication or recurrence. This is a mini session in our retina course, and the next session will be discussing intraocular tamponades, its definition, what are the types, when we will use each of them, what are the indication on and the contraindication. We won't depend on just recalling the indication and the contraindication. When you understood the characteristic and the property of each one of them, you will conclude the indication or the contraindication, when we should use it, when we shouldn't, when we must not use it by yourself. We are used to having a mind mapping for ophthalmology. We agreed that we don't recall information, we just conclude and complete the spaces after getting the main idea. So thank you for this small session. I hope after you have seen these great videos you have a clear idea what are we doing, cause and I chosen to have 3D and the graphics instead of real videos of real operation, because real operation actually may be somehow confusing for you. So you have to see the clear video and the clear image first, then you see videos and for real operations, and then you see it at real. And in next session I'll show you some realistic video what are we doing in operations. I thank you so much. I hope you got it. This was Dr. Sharif Naguib. Thank you again.